Hey guys, this is Dr. Shannon M, who's lipstick, with babies after 35. I am a maternal fetal medicine specialist, and today I am going to talk about obstetrical lacerations that can occur during labor and delivery. This is in response to a couple of videos I posted that I made on TikTok and also posted on my Instagram account. So I just want to give you guys some information as well as some tips that I might have and some other insight that I have from having delivered a gazillion babies. Yes, I'm a maternal fetal medicine specialist, but I still actively deliver babies with the residents and fellows. So it's still a part of my routine day-to-day job. And so I am still very hands-on. I push with patients. I teach residents how to avoid lacerations, how to repair lacerations. And the reason why I think this is important to address is because, and I tell the residents all the time, a laceration repair on a woman's vagina after a vaginal delivery should be taken just as seriously as any other surgery, because it's a surgery. In my opinion, if there's a cut and you're putting stitches in someone's body part, that is a surgical procedure, okay? So, and sometimes the tears are not that bad, and sometimes they're pretty extensive, and it can be pretty gnarly, for lack of a better word, to repair. So understanding the anatomy of a woman's vagina and vaginal vault, and to be able to restore it to the way it's supposed to be, and I don't mean restore to its pre-delivery state, and we'll talk about that. What I mean is restore it, put the anatomy back together the way it's supposed to, okay? And knowing your landmarks is extremely important. And also educating the woman on what kind of tears she had, what if anything, that means for her future delivery, what she should do to take care of it, and answer any other questions. She should know exactly where she tore. So I think it's very important that a woman has explained that. I know right after delivery, sometimes she's just not into it, either because I'm doing the repair and have a lot of work to do, or she's with the baby, or she's tired, whatever. But I make a point at some point when she's, able to listen and grasp, I'll let her know exactly where she tore. Okay, so here we go. Now bear with me, there's a lot of information. I'm going to try to answer some questions at the end of this, but this video will be available on my Instagram feed and on my TV later. So we're going to start off, I'm going to go back and forth. Maybe, can I? Okay, I might be able to do that. I'm going to try something new, so hang tight. Okay, hold on. Ooh, okay, let me see if I can get this in there. Hold on. Bear with me, guys. I'm trying to make this work. Okay, let me get this. There we go. I'm trying something new because I want you guys to have some infographics here. Okay, here we go. All right. So first we're going to talk about the anatomy of the female vaginal perineum and perineal pouches. So here we go. So the external female genitalia are composed of the mons pubis, this fatty pad, sometimes more fatty in some women than others. Every woman's body is different. That's right here on top, above the pubic bone typically, or right in the pubic bone area. The labia majora, which is the outer part of the vaginal vault here. The labia minora, which are the tinier or smaller, we call them, you can call them lips. That's what most women refer to them as. But on the inside here, the vaginal vestibule, which is down in here. The perineal body. That perineal body is that piece of tissue between the vaginal opening here and the rectum or the anus. That area there is the perineum, okay? During childbirth and having a vaginal delivery, you can tear anywhere there, okay? But the most common place to get a laceration is in the perineal body, that area of tissue between the vaginal opening and the rectum, okay? The perineal body is a massive dense connective tissue that includes superficial and deep muscles of the perineal membrane, and it also includes the transverse perineal muscles and attachments of the bulbocavernosus muscles. Those are right behind this area right at the top of the perineal body. The bulbocavernosus muscles are very important to put back together, put them back together correctly once, if there is a tear in the perineal body. Inferior to the perineal body is the anal sphincter complex, which is down here, okay? So you have the external anal sphincter, which is, when you're having a bowel movement, that's kind of what allows you to pass the bowel movement, but deeper inside is the internal anal sphincter. And both of those sphincters are equally as important to fix should they get damaged during childbirth, okay? But they're kind of, if this is the rectum here, the anus, they're kind of in a circle around. The external is closer to the skin, and the internal anal sphincter is inside deeper, okay? Oh, let's go back. So where can they tear? Hang tight. Perineal body is the most common place. You can tear into the vaginal vault. If you think of the vaginal opening here, it gets much bigger. Much bigger because of baby's head. So you can tear into the vaginal vault. You could tear on the labia minora, majora. You could tear around the urethra, which is this opening right here where we urinate out of. You can tear up on either side. This is the clitoris, under the clitoral hood here, under the prepuce of the clitoris. And you can even tear up around the clitoris as well, okay? So it's important to know where you tore, because you might find that some women don't even tear down here. They tear all up here, and I'll explain that later. So knowing exactly where your tears were is extremely important. Okay, here we go. Next, we have systems available to classify the severity of tears that a woman can experience during a vaginal delivery. And they kind of all relate to the involvement of the external anal sphincter and the perineal body, and the internal anal sphincter and the anal epithelium, which is what lines the rectum and the anus, okay? That's called the anal epithelium. There's no real consensus on how to classify these tears, and there's several different systems, but ACOG, which is the American College of Obstetricians and Gynecologists, we use a certain system, and I'll explain that in a little bit, to classify those tears. Now, those tears are the tears around the clitoris, the labia, the vaginal vault, inside the vaginal vault, around the urethra. Those are not really classified. That's just something that should be described when we document how we repaired a woman. So let's first talk about how do we classify the different perineal lacerations. We're going to talk first about first degree tears. Okay, let me get this up here. So the first degree tear of the perineal body involves only the perineal skin, which is the skin between the vaginal opening and the rectum, and the tissue that lies directly beneath. You might experience some mild pain or stinging during urination with this type of tear, and these tears may or may not require stitches, and typically heals within a few weeks. And here's an example of a first degree perineal tear. Okay, so if you see, this is a perineal body, anus, vaginal vault, vaginal opening, and it's just a slight tear right there, but it includes the skin. And then the vaginal mucosa, which is the skin kind of changes once you go into the vaginal vault, and that turns into vaginal mucosa, whereas you have epithelium out here that's closer on the perineal body. And for me, it depends on how long or how deep that first degree tear might be. I may or may not put stitches in there. I typically don't like to leave anything open, even if it's not bleeding, because I want to at least throw some kind of stitches in there, even if it's a small stitch, to bring that area back together, just to reapproximate and allow some healing. There are some physicians, if it's not bleeding, they will leave it alone, but that's up to the physician at the time of the tear. They have to make that decision based on, how involved it is. Okay, so it's a first degree tear. We're going to talk about a second degree tear, okay? A second degree tear involves the skin and the muscle of the perineum and might extend deep into the vagina, which means deeper into the vaginal vault, okay? Or also deeper down. Second degree tears typically require stitches and heal within a few weeks. This is the anus. This is a second degree tear. You see it goes into the vaginal vault, down the perineal body. And this is the anal sphincter, which is a circular muscle around the anus. And that is what contracts to keep women from defecating on themselves. And that's what is released when you do have a bowel movement. So a second degree tear may expose the anal sphincter, but the anal sphincter is not torn in any way. Okay? So as long as the anal sphincter is okay, if you have a secondary tear of the perineal body, it just remains at a second degree tear, okay? That's typically what they look like. These are perineal muscles up here, and those will be put together when we reapproximate the secondary tear. A secondary tear is going to require stitches and should be put back together, okay? Let's go up again. Let's go to a third degree tear. There is a third degree tear, okay? I'm going to say, I have all this written down, guys. I can't do it all from memory. I wanted to make sure I get some good information for you guys. So here we go, a third degree tear. Third degree tear is extended to the muscle that surrounds the anus or the anal sphincter. These tears sometimes require repair with anesthesia in an operating room rather than in a delivery room, and might take longer than a few weeks to heal. Complications of a third degree tear, such as stool leakage or fecal incontinence and painful intercourse, are possible. If these problems occur, you need to talk to your doctor. And if you look at it, this is why. Okay, so here we are. You have the second degree, right? The perineal muscles are torn. You have the tear in the perineal body and into the vaginal vault, the vaginal mucosa. But you can see here, here's the anus, and here's the external anal sphincter. that is torn as well. It may be torn halfway, all the way, okay? It's called a third-degree tear, and we further classify it by how much of the anal sphincter was involved. And that's a very subjective assessment. There's no real way to know exactly for sure, but we kind of make a determination based on what we see. It's very important that you put that muscle back together, because if it's not, it's going to be very hard for this rectal tone, or, it could lead to incontinence if it's not put back together properly. So we start with repair of the anal sphincter, then we go and repair the rest of everything, of the tear. Okay, so a third-degree tear involves the anal sphincter, is a second degree plus the anal sphincter, okay, in most cases. So let's go down to the fourth degree, the dreaded fourth degree. Let's talk about a fourth degree. So a fourth degree, I'm going to let you see my face for a second. So a fourth degree. This is feared and dreaded, but luckily it's not very common. And we'll talk more about that too. I have a lot of information for you guys. It's not very common, thankfully. So a fourth degree tear are the most severe. They extend through the anal sphincter and into the mucosa, or mucous membrane that lines the rectum mucosa. The fourth degree tears usually require repair with anesthesia in the operating room rather than in the delivery room, like the third degree, and sometimes require more specialized repair. Healing takes a lot longer, usually a good 6 to 8 weeks, and complications such as fecal incontinence and painful intercourse are possible. Again, if these problems are occurring, you need to let your doctor know. So let's look at a fourth degree tear. Here we go. Go down a little bit. Okay, now you see into the vaginal vault. The second degree, the external anal sphincter is completely torn through, and then it also tears into the anal mucosa here. So that is a much more involved procedure, as you can tell. It is a surgery. Most of my tears, for when a doctor might take a patient back to the operating room for a repair. My rule of thumb, it doesn't really matter what kind of tear it is. Obviously, if it's a third or fourth degree tear and I need better exposure, I'm going to go to the operating room. If there's bleeding and I can't tell where the tear is, I'll take her back to the operating room for better exposure and better pain control. Or if she needs pain control, I'll take her back to the operating room. The most important thing is that you have to be able to see so that you can fully evaluate the vaginal vault and know where the tears are and that you didn't miss any tears. So however you get that exposure, however you get that pain control, so you're able to see and look thoroughly. If that means going to the operating room, that's exactly what I will do. Okay? I don't like to struggle repairing any woman's vagina because I want to do it right. And so that means if I need better exposure, better light, better pain control, she's going to the OR. Okay? All right. Fourth degree. And I know it looks gnarly, and it is. Fourth degree is pretty gnarly. Okay. In 1998, the 1998 to 2010 U.S. nationwide inpatient sample reported a third degree laceration rate of 3.3% and a fourth degree laceration rate of 1.1% for women who had vaginal deliveries. So that's from about 1998 to 2010. Again, 3.3% of women delivering vaginally had a third degree, and 1.1% had a fourth degree who delivered vaginally. There's a wide variation, though, in how these stats are reported. So this is the best guesstimate of how many women have third degrees versus fourth degrees. And again, this data is 10 years old, and we're probably due for some new data. And it's also going to vary based on how these injuries are classified. Okay, so you can't control for everything. Sometimes you weren't there in the procedures. So as a researcher who's trying to put this data together, we have to go by what's there. So basically, because of all those factors, there was one study that kind of reviewed all the data out there, and they noted that there's wide variation in reported incidence of childbirth associated sphincter injury or third or fourth degree tear, and they estimate the true incidence of approximately 11% in women who deliver vaginally. So they're saying that it's more likely that 11% of women delivering vaginally can have a third or fourth degree tear. Okay, and I think it depends on where you are. I don't think that's true where I work. But we haven't looked at that data just based on my own personal experience, but that may be very well true. Okay. All right. So let's talk about episiotomy. So episiotomy is a surgical enlargement of the posterior aspect of the vagina by an incision to the perineum during the last part of the second stage of labor. And that's when she's pushing. So basically, if we go back up here. Okay. So this is the vaginal opening. Pretend the baby's head's there, and this is much wider. Okay, the area is much wider. An episiotomy is when I physically take a pair of scissors and I cut, all right, into the perineal body and a little bit into the vaginal vault. A midline episiotomy is if I go straight up and down, in this area. And there's also something called a medial lateral. The most common is going to be towards the patient's right because most physicians are right-handed. So we might cut, instead of cutting up and down, cut to the side. Okay, so that's where the episiotomy occurs. Let me go back. So it typically occurs right before the baby delivers, and there's various reasons why we might do that. Okay, so let's look and say, from about the 1920s forward, the most popular medical belief was that an episiotomy made a cleaner cut that could be easier to repair and heal better. The logic was also that getting an episiotomy would prevent a worse perineal tear. Okay, so that's what used to be thought, but starting in the 1980s, high-quality research on episiotomies was released, demonstrating that routine episiotomies, meaning going ahead and cutting with every delivery an episiotomy, can cause the very issues they were trying to prevent, leaving many women with more severe tissue trauma and other negative long-term outcomes, including painful intercourse. Okay, so just to give you some stats, in 1983, approximately 60% of women received episiotomies. By 2002, it was down to 33%, and then those rates have steadily decreased since 2006, and based on 2012 data, approximately 12% of vaginal births include an episiotomy. Okay, again, precise definitions for the type of episiotomy have been proposed based on the angle of the cut and the direction of the incision, but the more common type of episiotomy that's performed in the U.S. is the midline, like I showed you, right between in the perineal body, straight up and down between the vaginal opening and the anus. In Europe, the medial lateral is more common, where we go to the side instead of straight up and down. But current data and clinical opinion suggests that there are insufficient evidence to recommend an episiotomy, especially the routine use of an episiotomy. So clinical judgment remains the best guide for this procedure, which means we should not, as obstetricians, be cutting an episiotomy on everybody just because they're delivering vaginally. It should be done when it's indicated. Now, what is an indication? I think every obstetrician is different as to are their indications for an episiotomy. I will tell you some of mine. If I feel, because when you're pushing with the patient, you can see after the perineal massage, and we'll talk about that, after other things you could do to try to loosen up that area. If I feel too much tension on that perineal body, and I feel that if this baby comes up vaginally, she's going to end up, I know this is terrible terminology, exploding her vagina or causing a big lacerations both up and down, I might cut an episiotomy to give her a little bit more room so that won't happen. If you have to do an operative vaginal delivery, a forceps or a vacuum, it might be important to cut an episiotomy. If there's a shoulder dystocia where the baby gets stuck and you can't deliver this shoulder and you only get to the head, we're not going to go into shoulder dystocia, but that is a reason to cut an episiotomy in order to get more room, so we can get our hands in to manipulate the baby to get the baby out. What are some other reasons for episiotomy? If sometimes women will come in and they've had previous tears before, and sometimes they will tear again, especially you could tell sometimes that they've had a 3rd or 4th degree. If I'm trying to avoid that area, sometimes I might cut a medial lateral to try to keep them from tearing through that area again. That's very rare, but the reasons why I told you, Ruth previous mentioned, are the main reasons why I would cut an episiotomy. It's a game time decision, meaning it happens right then as the baby's starting to come down and she's getting ready to deliver. It's not something that I decide at the beginning of her labor process. You don't know until you're there. But it is a skill set that every obstetrician should have, because sometimes it is needed, okay? But I agree, routine episiotomy should not be done. Okay. Risk factors for anal sphincter injuries, meaning the 3rd and 4th degree tears. So the strongest risk factors includes forceps delivery, vacuum assisted delivery, midline episiotomy, meaning we cut an episiotomy for whatever reason, some of the reasons I mentioned above, and then when the baby delivered, the tear went all the way through. So if you remember what I said, when people were doing routine episiotomies, they found that it was causing the injuries that they were trying to avoid, and that's because when they cut the midline episiotomy, they were finding that could cause the women to go ahead and go into a 3rd or 4th degree tear. So that's why we stopped doing that. So if I cut a midline episiotomy for whatever reason, there is a chance that it could extend through and go on into a 3rd or 4th degree tear. So that is a risk factor for a 3rd or 4th degree tear. And a large baby. So a large baby is more likely to cause a 3rd or 4th degree tear, and that's not just because the head's coming through, but if you have a big baby with a big head, it's going to have big shoulders, and a lot of times as that shoulder comes through, it just tears through. Okay, so it's not only the head that could cause it, but the baby's shoulders too, because they're coming down on the where that third or fourth degree could occur, and that could help that to occur as well. Okay, a midline episiotomy combined with forceps delivery substantially increases the risk of a third degree laceration and a fourth degree laceration. So, for example, if you are doing a forceps and you have an episiotomy that's done, and then that could go on into extend into a third or fourth degree. Other risk factors include being a first-time mom and never having had a vaginal delivery, Asian ethnicity, induction of labor, epidural anesthesia can cause that, and persistent occiput posterior, meaning the baby's sunny side up. So those are some of the risk factors as well, okay? So let's talk about prevention strategies for obstetric lacerations. So what are some things that women could do, or that I could do, I have some wild hair here, that I could do to help prevent a woman from tearing? The first thing we're going to talk about is antepartum, meaning before delivery, or intrapartum, meaning during delivery, perineal massage or support. So perineal massage, either before delivery, while you're still pregnant, or during the second stage of labor, is intended to decrease the perineal muscular resistance and reduce the likelihood of laceration at delivery. Digital perineal massage from 34 to 35 weeks onward, not earlier, 34 to 35 weeks onward, has been associated with modest reduction in perineal trauma that could require repair with suture and may decrease episiotomy in women without a previous vaginal birth. And I'm going to show you some pictures. You or your partner can use daily perineal massage from 34 to 35 weeks onward until your baby is born, which may reduce your risk of tearing. This is particularly helpful for first-time mothers. You may choose to ask your partner to help you with this. So perineal massage tips. You can sit in a warm bath before you start. This may help you to relax before the massage and loosen the muscles around your perineum. Make sure you have short nails, because you're going to use your fingers to massage that area and you don't want to cause irritation. Comfortable position. You need to be in a relaxed position during the massage, so it's important that you find whatever's comfortable for you. The best place to perform this massage is in bed, so prop yourself up with pillows to support your back and bend your knees. You can use a lubricant like vitamin E oil, almond oil, or olive oil, and use your thumbs, and I'll show you a picture. Hold your thumbs in the position shown, and I'll show you the picture. For about 1 minute, press downwards towards the anus and to the sides of the vaginal walls. Hold your thumbs in this position for about 1 minute, and you'll begin to feel a stretching sensation, and you breathe deeply. So let's go back down, then I'll come back. So here we go. So see, okay, anus, thumbs. Now, that would be your thumbs, okay? But your partner could do it too. It's just that they would need to do it, whatever position is comfortable for you. So you kind of put your fingers in right inside and just kind of push down and out and hold it. Down and out and hold it. Okay, if that makes sense. You could also do a gentle massage of the lower half of your vagina using a U-shaped movement for 2 to 3 minutes, and repeat this 2 to 3 times. You can repeat this daily, and it may take a couple of weeks for the daily for this to start working, and before you start noticing that things are getting loosened up there. Make sure your hands are clean before you do this, your hands or your partner's hands, and start around 34 to 35 weeks. This might be especially important for first-time moms, because think about it, you've had a vaginal delivery before. The chances that things are going to be a little bit looser there for the next delivery and the next delivery and the next delivery are greater, and women are less likely to tear as they have more babies. Okay, so this is the perineal massage. Okay, now perineal massage during the second stage of labor, meaning while a woman is pushing. Okay, this may also help reduce the third and fourth degree lacerations. Basically, as obstetricians, when we're pushing with you, we can do the same thing, similar to what is being shown in that diagram, but we're doing it, and you can feel things getting loose. I also explained to her, do you feel my fingers here? Yes, even with epidural anesthesia, and I can tell. Let's say a woman who does not have an epidural. I can tell by putting my fingers right inside where she's tensing up. And women without anesthesia, it's hard not to, because you feel everything. And a lot of women do tense up, and they tense those muscles around that baby's head, and it makes it a little bit harder for the baby to come on through. So I'll tell them, right here, relax that muscle. And I'll try to guide them and say, relax that muscle. And I kind of coach her through it so she can get a feeling of where she needs to relax in that area when she's pushing, okay? Manual perineal support at delivery is commonly practiced, and this is, again, with obstetricians or obstetrical care providers, and that's considered a hands-on method. And there's multiple techniques that can be used for a hands-on method. Supporting the perineum, meaning as the baby is coming down, we put a hand like this where your perineum is to kind of keep the baby's head from just poking, pushing through. A lot of times, women are pushing so hard. And if they don't have an epidural, they're pushing so hard, it's hard to rein in that force. And the next thing you know, baby's head comes popping through. So I try to put some pressure there to not allow the head to just pop through, which can increase her risk of tearing. Or if you don't have an epidural, you could be pushing so hard and not realize you're pushing that hard, and the same thing can happen, okay? So we try to put some perineal pressure on that perineum to keep that baby's head from popping through and potentially tearing, okay? Manual perineal protection can be provided in any birth position, and it is only used for a short period of time during the birth of the baby, and it can help reduce the severity of tearing. There's a lot of things we can do. Those of us that have been doing it a long time, we know what we like. We do certain things and coach and explain things to the patient, whatever has worked for us. But I think it's very important that we develop that skill so that we can let them know. I go down to exactly how she's positioned in bed. I look at how, where she's putting all of her force, because a lot of times they push so hard and their face is turning beet red. And I'm like, that's not where you need to be pushing. You need to be pushing down here. And sometimes you have to look at her body, kind of like the scene of a play. Look at her body and see where she's putting all that force, because sometimes I'm looking at her and she's grabbing on to whatever's so hard up here, and nothing's going on down here because all of her force is up here. And it's all about coaching and directing and trying to let her know where she needs to put all that force, because we don't want her to waste all that good force when it's all up here and not down in her bottom, okay? So having a physician or the nurse, in some places the nurses are the ones who's pushing with you, that can help you learn how to do that. And it does take a learning curve, okay, especially for first-time moms. It is really, really important, okay? Talk about warm compresses. So warm compresses on the perineum during the second stage of labor or while pushing can reduce third and fourth degree lacerations. Warm compresses do not increase the rate of a woman having an intact perineum after delivery. So what that means is using warm compresses can decrease the risk of a third and fourth degree laceration, but it does not decrease the risk of not tearing at all. You still might tear some, it's just less likely to have a third or fourth degree laceration. Excuse me. Warm compresses also have been shown to be acceptable to women and are therefore reasonable and to offer. Because application of warm perineal compresses during pushing reduces the incidence of third and fourth degree lacerations, OBGYNs and other obstetrical care providers can apply warm compresses to the perineum during pushing to reduce the risk of perineal trauma. So I think that's perfectly fine too. I'm all for that. As far as what laceration, and we're going to touch on this. There is some data out there about changing positions and pushing all these crazy positions, but I'm not going to go over that, honestly, because based on two things. Number one, the data is conflicting, and there's no real data that says that helps. Pushing knees to chest, pushing on all fours, but none of that's shown to decrease lacerations or third or fourth degree lacerations. And also, I've been delivering babies for 20 years now, and I haven't found that it decreases. I think it's important to see where your patient's pushing and coach her and let her know, hey, try this, because, the more involved you are and the more, of a connection you have with your patient, actually it can happen pretty easily. So I'm particularly good at that. I'm going to pat myself on the back a little bit. I love pushing with patients. So, but I'm also interested in it, and I want to protect her perineum. So you have to be invested in it and be willing to help her so that she can push effectively and not tear her bottom. A lot of times I'll tell a patient, listen, you're pushing wonderful. This baby's head's coming down, but when it gets close, I'm going to tell you to stop. And what I want that head to do is kind of sit there for a minute and allow further stretching, and then I want you to push for 50% of your, not 100%, 50%. And that's ease the baby's head out a little at a time, a little at a time, a little at a time. And I find that when I do that and the patient really listens, the head just kind of comes on out, sits for a minute, comes out, sits for a minute, and all that time it's stretching. And next thing you know, she has a baby and there's nothing there. And maybe have a little bit of what we call a skid mark. A skid mark means it's not a tear. It's like a skid mark. It's like if you skinned your knee and you don't even have to put stitches in, okay? But I'm invested in coaching her through that to try to avoid the tears, okay? So that techniques really work for me, and I kind of coach them about it before they even get to that point. This is what I'm going to do. So when it's so funny because women are like, I'm pushing, and then all of a sudden I'm like, stop, and they're like, wait. I said, now listen, we're going to do this. And I don't like having everybody, the mom, the dad, and this is pre-COVID times. We're not going to talk about COVID and pushing, okay? But the nurse, everybody push, kind of good, counting to 10. I just want it to be me and her, because I'm the one delivering the baby. I want her to listen to me, and I'll ask everybody, just quiet down for a second. I like to be as calm as possible. Now listen, this is what we're going to do. And then all of a sudden, it just like a light bulb hits, and out comes the baby. Now, does that work 100% of the time? Absolutely not. There are times when it doesn't work no matter what I do, but most of the time it does work, okay? All right. So which obstetric lacerations should be repaired? Diagnosis of obstetric lacerations in the setting of perineal trauma requires adequate lighting, exposure, and anesthesia, okay? Like I said earlier. If a deep perineal laceration is noted, a digital rectal exam can improve the diagnosis of external anal or internal anal sphincter lacerations. So anytime I have a 3rd or 4th degree tear, I'm going to do a rectal exam before and after to A, see how deep it goes, and then B, after I'm done, to make sure no stitches went through, or that everything was repaired correctly. So there's certain things that we can gauge to know that we did a good job, okay? When complex lacerations exist, or if there is excessive bleeding, a better positioning, visualization, suitable lighting, and assistance may be necessary. I am all for going to the OR for a repair, because I don't want to miss anything. I don't want to miss anything, and I want to be able to see. And sometimes, if she's having uterine atony and bleeding from the uterus, which happens after delivery, I can't see. If she doesn't have anesthesia and I'm mucking around in her vagina and it hurts, and she's clamping and I can't see, and I'm like, I'm not going to torture her. I don't want to torture her. Listen, let's just go back to the OR where I can see. We'll give you some anesthesia, and let's get this done the right way, okay? My goal is to see, and my goal is to not torture anybody, okay? So that's important too. Yes, I know that it separates the mom from the baby for that period of time. I get it. But I don't want to mess up and miss something because I don't feel like I can see enough to be able to confidently know that I repaired her. And I hate that part. I get it. But that's what I'm going to do. I would hate to think I repaired it and then something happened and I didn't. I want to be able to see. Okay? And there are plenty of times where she has good anesthesia and she's fine with me, and I could put my hand in there or whatever retractors and I can see fine. That's great. I'll do it in the room while the baby's on her chest. I do not mind that at all. But if there's anything that's preventing me from doing that, I'm going to take her to the OR. Okay? All right, periclitoral, periurethral, and labial lacerations. So we're going to talk about this again. So periclitoral means around the clitoris up here. I've even had tears that went straight through the clitoris. Those aren't as common, but it does happen. Periurethral means around the urethra. And labial means labia majora or majora on this outside here. Those are called the anterior vaginal area, or in the labia. They're usually superficial. They usually don't have a lot of bleeding. But for me, if the anatomy is distorted, and a lot of times those tears around the clitoris and the urethra, the labia minora, they actually don't always bleed, but sometimes they're just wide. And I want to reapproximate that just to get the skin edges together so A, when she pees, it doesn't burn like hell. B, that the skin edges come back appropriately and are given a chance to heal appropriately. Okay? If I just leave it there, I'm afraid that it's going to heal and the skin edges are going to be all janky. And, if she does happen to wipe, which, after you have obstetric lacerations of any sort, they instruct you to use the sitz baths and things like that. Yes, but at some point you're going to wipe. And you're not going to not wipe for 6 weeks. Okay? This is unrealistic. There's likely still going to be stitches there, so you need to know where the stitches are. And I don't want someone to freak out if there's stitches there and they didn't expect it. That's another reason why to always ask where you tore. But that area up here, I'm going to go back. The area up here is so important, okay, to repair correctly. It's just as important to repair this area, even though the tears are may not considered as major, as it is to repair down here. Because up here you have your urethra where you pee out of every day, and up here you have your clitoris, which is important for female sexual function. Don't want to jack that area up. I'm going to make sure I fix it right, okay? And it's also important that you know if you tore there, okay? All right. Let's see. So expert opinion generally is to repair periclitoral, periurethral, or labial lacerations that are bleeding and distort anatomy. I agree. So if I feel like it's bleeding, obviously I got to repair it. If it's distorting anatomy, and distorting anatomy is kind of subjective, but if I have the feeling that even though it's not bleeding, like I said, it's not going to come together right, I'm going to put it back together so it has a chance to come together right, okay? All right. Now, we're going to talk about the husband stitch. I did a video recently, which got a lot of attention, so we're going to talk about it. Bear with me, and then we're going to answer some questions. The husband stitch. Yes, it really happened. It may still happen. I don't know. But yes, it really happened. It's called the husband stitch or daddy stitch. It refers to an extra stitch that some women may have received after vaginal delivery, after a vaginal delivery led to their perineum being cut from an episiotomy or tearing spontaneously. The stitch extends beyond what is necessary to repair a natural tear during childbirth or a cut from an episiotomy. The supposed purpose of the husband stitch is to tighten the vagina to its pre-delivery state. I'm sure a woman did not come up with this. The origin of the husband stitch or vaginal tightening surgery traces back to the mid-1950s. While repairing a vaginal delivery or episiotomy, a gynecologist would tighten the entrance of a woman's vagina by adding an extra stitch. So let me show you what that means. The entrance. Okay, hold on. The entrance, which is this area right here, not the vaginal vault. And you have to understand, when you're pushing a baby out, the baby's coming down the entire vaginal vault, not just the entrance. So if you're only doing an extra stitch or two at the entrance, you're doing nothing about, quote unquote, tightening the vaginal vault or restoring the vagina to its pre-delivery state. That makes absolutely no sense. And if you put that extra stitch there at the introitus or entrance of the vagina, right here superficially, think about having intercourse after that. It's not going to be ideal, okay? So whoever thought of this in the 1950s, whatever, I'm not sure what they were thinking. Okay, anyway, I digress. Doctors stated that this procedure could improve a woman's well-being by preserving the size and shape of the vagina, which is not accurate. Putting one or two stitches right at the opening of the vagina is not preserving the size and shape of the vagina, because the opening is not the vagina. The vagina goes into the woman's body where the uterus is. That is the vaginal vault, okay? So one or two stitches at the opening is not going to do jack, okay? So that makes no sense, all right? Here we go. Doctors stated this procedure could improve, okay, I already said that. Also, they stated that it could increase the frequency of her orgasms or enhance a man's pleasure in intercourse, which, listen, let's be real. The reason why this was being done is to enhance the man's pleasure. That's why, okay? Not anything else. Nobody, I just can't. Anyway. Okay, at that time, it was also called the husband's knot or a vaginal tuck. But let's talk about the vaginal birth canal. The vaginal birth canal is not just a very superficial opening. It starts up by where the cervix comes and the cervix opens. The baby descends through the vaginal vault or the vaginal canal, and it actually just eventually emerges from the opening. But a lot of work's done before it comes out of your body through the vaginal canal, okay? So that's the vaginal canal. All right. So the vaginal birth canal is a muscle, actually a bunch of muscles. So, and I'm going to show you a picture that allows the baby to pass through for delivery. Sometimes the vaginal opening may not stretch wide enough to accommodate the baby's head. Rather than risking a serious vaginal tear, the doctor or midwife would perform an episiotomy. So it kind of also went with the thought of routine episiotomies that they were cutting, and they would just put in those extra stitches or the husband stitch at the very end to tighten the very opening, not the vaginal vault. It was doing nothing for that. That leads me to believe that the real reason to do that was to increase a man's pleasure when having intercourse, because it makes no sense that those few stitches in the opening is going to repair the vaginal vault, okay? There you go. Husband stitches may have been more common when episiotomies were routine. And I do believe that. And I will say this. I did medical school 1996 to 2000. I did residency 2000 to 2004. I saw this happen. I didn't really understand, and keep in mind, I wasn't very sexually active myself. I didn't know a lot. I had one boyfriend and had first time having it, as it's probably TMI. I was 21, but I didn't realize what it was. But the ones that were doing were the older school gynecologists, obstetricians who were. It was a joke. After the baby was delivered, hey, let me throw in a couple more stitches, and the dad would be like, sure. Or the dad would even ask them to do that. Meanwhile, the woman's sitting there, and a lot of times the woman's not even realizing she just pushed a human out of her body and didn't realize what was even going on because she's in that state of euphoria or sometimes hurting because for whatever reason. So she's not even listening to this going on. This is times that I saw it was an exchange between the physician and the dad, not the physician and the mom. Okay? So yes, I have seen it. But I have not seen it in a very, very long time, thankfully. Okay? In a very long time. Okay? Does it still happen? I would love to say no, but I can't say for sure. I don't know. I just know that I've never done it. None of my colleagues have ever done it. And I just hope it's not being done. So that's why I'm doing this. I get kind of back and forth when I said I was going to do this. Well, that's not done anymore. And then I hear what's being done all the time. I don't know what's true. Okay? So it doesn't matter. I don't know. But just in case, I just want women to know that that should not be happening. Okay? But I also want to say this. If a woman has a very involved tear, it could be possible that things get sewn too tight because it's hard to gauge, especially in a post-delivery vaginal vault that has a lot of tears or extensive tears, how tight you're worried about getting everything back together, that I can see it happening. So I don't want women thinking that just because they're having these problems that someone put a husband stitch in me. And I don't even know how that assessment would be made. But what you can do is talk to your obstetrician and gynecologist about that from the very beginning. Okay, and I would hope no one would ever say that is something they would do or would even consider. Okay, so I don't want all women thinking that because they're having issues with intercourse or pain after a vaginal tear or obstetric laceration repair after a vaginal delivery that that's what was done. I don't know how to tell you to find out if that was done. It's not common. This is 2020. This should not be happening, and it can still happen. Even if we're not doing a husband stitch, just through repairing, because sometimes it takes a lot of work to repair a woman's vagina, especially when she's had a bunch of tears. Does that even make sense? I know it's a lot. I'm not trying to defend anybody or dismiss anybody who thinks they had that done, but if you are concerned about it, you need to be seen. The people that you could see just while we're at it are called, it used to be called urogynecologists. They're now called FPMRS surgeons, or female pelvic medicine reconstructive surgeons. If you're having trouble post-repair, post-obstetric laceration repair, especially if you've had a 3rd or 4th degree lac, and you're still having painful intercourse, you're still having pain, you feel that things are just not right down there, you're having fecal incontinence, urine incontinence, after a vaginal delivery, you need to see one of these docs to find out exactly what's going on, okay? Having a baby through your vagina can cause damage. It can cause damage, and it does cause damage, okay? So you have to keep that in mind. Okay, let's see. I'm going to finish this part. Okay. Regardless of whether a tear happens on its own with an episiotomy or as a result or naturally, the husband stitch would not affect the overall vaginal tone, as I said, as this is much more to do with the pelvic floor strength and integrity than with the actual opening of the vagina. Okay. Let's see. It is possible, however, to create a tightness on the perineum and outer vulva with stitching, like I said, although it's debatable if sexual partners can feel it or not. Perhaps the husband stitch is a holdover from a time before doctors understood vaginal tone and believed that they were turning women to prime sexual function after birth. I don't know why they did it. Long story short, it shouldn't be done. So contrary to the common misconception, long-term studies have shown that sexual function and satisfaction are not affected by childbirth, neither vaginal nor cesarean section. Sexual function is not related to the tightness of the skin, but rather the underlying muscle tone of the pelvis. So adding unnecessary tension to the skin at the opening of the vagina is not going to help. Let's talk about this underlying muscle tone. So if you look at the, ooh, I gotta flip. Hold on. This muscle tone. So this is really cool. This is if a woman is staying sideways. So this is her pubic bone, bladder, uterus, rectum. See this line of muscles here? Okay, that's the pelvic muscles. It's kind of like a sling of muscles where the urethra goes through, the vaginal vault goes through, and the anus goes through. So the sling of muscles here is what supports all these things. If you have delivered 1 baby, 2 babies, 3 babies, 4 babies, that's more strain and stretch and potential damage to that pelvic floor, which could cause urinary incontinence, vaginal prolapse, anal incontinence. Okay, it's more common that you can get urinary incontinence and vaginal prolapse after multiple vaginal deliveries. You can have more of the anal incontinence or problems with defecation if you've had a 3rd or 4th degree laceration. But think about it. You're pushing a baby through those muscles there. Yes, it's coming through this vaginal vault, but it's dilating to up to 5 to 6 inches or more to accommodate a baby's head, or sometimes even larger on bigger babies. So passing a baby through that vaginal canal multiple times and through that pelvic floor muscles multiple times can lead to damage over time. And so if you're having any issues with the things I just mentioned, urinary incontinence, vaginal prolapse, uterine prolapse, sometimes it can be so weak, these muscles, that the uterus even prolapses. Anal or fecal incontinence, see one of those FPMRS, female pelvic medicine and reproductive surgeries docs, or they used to be called urogynecologist. Where's another picture I have? And this is another picture, okay, here we go. This is the pelvic floor muscles. This is if you're looking, you cut me right at my hips and you're looking down into my pelvic floor. This is the coccyx, or the tailbone. This is the pubic bone. So back to front. You see urethra, vagina, rectum. See how they go through this sling of muscles? Now you pass a baby through that multiple times, and it's different for every woman. Every woman. I've seen a 21-year-old who's had 2 vaginal deliveries have uterine prolapse. I've seen a woman who's had 7 vaginal deliveries and have none. So there is a genetic component. It is different for every woman. It doesn't mean every woman that has multiple vaginal deliveries is going to have an issue, but just think about it. That's a sling of muscles there in the pelvic floor. And so all 3 of these things, the rectum, the vagina, uterus, and the urethra, can be affected, okay? So the last thing I just want to say is, there you go. It's important to note that the husband stitch is neither an accepted practice or an approved medical procedure. Researchers have gathered most of the evidence about the husband stitch from the testimony of women who have had it and from healthcare workers who have witnessed it. So yes, we know it happened, and I hope that it's not still happening, because we've had in many years just to prove that it shouldn't be done. If you're having issues with painful intercourse, a tear that's just not healing, you need to be evaluated. This is not something that should be let go. And that's why I tell a woman that I tell my residents, you have to take these vaginal laceration repairs just as seriously as you would take any other surgery, because I don't want to send my patient home with a new baby and she can't even sit on her bottom because I didn't do a good job. Okay? The last thing she should need to worry about, and listen, you have to repair, it's going to be painful for a certain period of time, but if I did a crappy job, could you imagine sitting on that every day and having to go through that? And that's how I kind of put it in perspective for my residents and fellows. We have to put as much attention to that repair as anything else. We have to know the anatomy, and we have to do a good job from the get-go so that they don't have to worry about that part for when they go home. Okay? So that's my spiel. I've only got about 10 minutes to answer some questions, so let me go through. Let me see what I had. And I won't get to everything, so I apologize. Maybe we can do this again. Hold on, I'm looking. What is a sulcal? It's called sulcal. Elizabeth Schiller, S-U-L-C-A-L. In the vaginal vault, okay, they have the introitus of the vagina and the vaginal vault. There's 2 areas, one on the right, one on the left, called the sulcus. And a lot of times those tears can occur with or without a perineal tear. A lot of times it happens with a big baby or a quick descent into the pelvis, meaning a woman went from 3 to complete, 5 to complete in a very short period of time. That comes down, or if it's a big baby and it's broad shoulders, those shoulders or elbows can tear the sulcus as you come down. So again, sulcal tears can be easily missed. And a lot of times you don't realize you have them until we finish repairing whatever else and she's still bleeding. And then we're like, okay, where's it coming from? Is it coming from the uterus? Well, no, that's good. Then a lot of times a sulcal tear was missed. So that's another reason why I'm so adamant about making sure we have good exposure. Okay, I missed a sulcal tear once in my career. I was a resident and I felt so shitty about it. And I felt like such a failure that I was like, I am never missing that ever again. And I never have. I will not. Okay, so I am so adamant about exposure. Okay, if you want to look it up again, it's sulcal, S-U-L-C-A-L, sulcal tear. I wish postpartum we would get a form that has a picture of the anatomy and marks. Yeah, that would be, actually, that's a good idea. YM cast, that's a good idea. People always say I tore, but I have no idea where and to what degree. If it was a shoulder, it would be different. Yeah, I'm going to also say this. I'm not placing any blame on a woman. I can probably count on 2 hands how many times in my career that a woman actually asked me where she tore. A lot of women don't. Maybe it's because of the euphoria of a delivery, of the exhaustion of delivery, and their mind is elsewhere. I get it. Just make sure you ask. I volunteer the information because repairing a woman's vagina and vaginal lacerations, perineal lacerations is actually one of my passions and one of the things I feel like I'm really good at. So I am very proactive about it. Not all doctors are proactive about telling them, and if they don't ask them, but ask. Okay, ask. Okay. Yeah, anal sphincter injuries, MW4DTS. She wrote that obstetric anal sphincter injuries are also underdiagnosed, initially diagnosed as 1st or 2nd degree tears, and then later found to be more. And that's true. That's true, unfortunately. That is true. That's why exposure and adequate anesthesia are crucial to a good repair. If I can't see and I can't tear, you're going to the OR. And I know some women get so upset about that and think I'm being too conservative, but I'm sorry, I don't care. I want to know what's going on with your vagina so I don't miss anything like that. Okay, so you have to just kind of trust your doc. And I would much rather overcall it and get back to the OR and not be as bad as I thought, than to undercall it and assume it wasn't something and then this happening and it's actually a 3rd or 4th degree and I missed it. It's always better to overcall it than undercall it. Okay? Let's see. Rectovaginal fistulas are devastating and more common than people think. Please do a thorough repair. Yes, rectovaginal fistulas do occur. Why they occur? Yes, it can be due to a poor repair. It could also occur due to a protracted labor where a woman was either pushing for a long period of time or laboring for a long period of time, and that pressure, especially if it was a big baby, in the vaginal vault, which the rectum is right behind that, and a long period of pressure on that area for whatever reason can cause it as well. So yes, they can be related to obstetrical tears, but they can be unrelated too. They can occur without a severe obstetrical tear, so they can occur. Okay. If you have dark skin, do you get hyperpigmentation? I'm not sure what you're saying. So if women of color, so it depends. I think if you're a woman of color and you get a skin knee, or you already get hyperpigmented, then it's likely to occur in your perineal area as well. So yes, that can occur. So there's a question about female pelvic medicine and reconstructive surgery, reconstructive surgery, FPMRS, or urogynecologist surgeons. Can they repair a female genital mutilation? So we won't go into what female genital mutilation is, but it is a practice in countries, not here, it's not supposed to be, but in other countries. Can they restore it back to what it was? Probably not, but they can potentially relieve some of the scar tissue and make things better for you. I have seen that done, but you also need to find a doc, a FPMRS, who has experience with it, because keep in mind, U.S. doctors don't see it a whole lot. In certain areas of the country, they're going to see it more, because the women who have had female genital mutilation and are coming from countries that do it, maybe more concentrated in certain areas of the country, and as a result, those doctors see it more. But you got to find an FPMRS surgeon, and also one who has seen this. Okay, so if you have had that done to you and you need help, that's where I would start. I'm going to do another talk eventually about pelvic floor exercises for women who have had tears and or childbirth. I have a couple of people in mind, but I'm kind of narrowing it down as to who I'm going to invite to do this, because actually I need more education on it too. So I'm super excited, and I want to pick the right person to do this. So I'm going to talk more about the different PTOT stuff that you can do for your pelvic floor, but I need to find the right person. Okay, so that's coming. Elizabeth Schiller is saying that her first baby was 8 pounds and born in 25 minutes after the water broke, and that's called a quick descent. When you have a precipitous delivery, meaning it happens very quickly, and or a quick descent, that can increase your risk of tears as well. So yes, she said we're talking about female genital. It's not supposed to happen, and it's not a common practice, but there are cultures that are within the United States where it does happen. It's not something that is. I don't want to say the wrong thing. So you're right. Yes, it does happen in the U.S., but it is not supposed to be illegal here. I don't want to misspeak, but I'm sure it does happen to young women here. That's a whole nother topic. Maybe I can find someone eventually that can help me address this topic. So yes, Fashionista Gallery, thanks for bringing that up. How often do you see a true rare cephalopelvic disproportion? An issue with this? An issue with a woman's pelvis being too small and misshaped, not based on the visa. So cephalopelvic disproportion is a very broad category. A lot of times, if the baby's coming down in a weird position and not in the right way, and or you can't push the baby out, you can assume that there's there might be some form of CPD, cephalopelvic disproportion there. But it doesn't mean I'm not a doc that's going to say because you're a pelvis you are never going to deliver vaginally. I'm going to give every woman a chance. That was kind of old school, that people used to do assessments of the pelvis and then automatically off the bat offer a section. We don't do that. So, but there's times when women deliver vaginally that baby's head's all cone shaped on the weird, jinky position and a weird shape. So that's an indication of CPD as well. Yes, it can happen. Would I ever have a talk with a CNM? Yeah, I work with CNMs. I have nurse midwives. They deliver on the same labor delivery where I work. They take care of the low-risk patients, and I have no problem talking with a CNM. I guess it depends on what the topic is. So, I have 2 more minutes, and it's going to shut me off. So, why is it so important to allow a woman to deliver vaginally? Why not? Listen, there is also a problem. Let me back up. There is something called an elective primary cesarean section, meaning a woman has no indication for a cesarean section and she wants it for whatever reason. After counseling about the risk of the C-section,